All right, welcome to this explainer. We're going to take the incredibly dense, honestly kind of intimidating biomechanics of human walking and translate it all into a crystal clear clinical roadmap. Whether you're actively assessing a patient in the clinic or just prepping for your rotations, understanding the exact mechanics of a single step is absolutely vital. So let's dive right in.
So right off the bat, I want you to totally reframe how you think about everyday movement. Just look at the quote here. Walking is a complex, repetitive pattern of controlled falls and shock absorption. Think about that for a second. Every single time we take a step, we are literally throwing our center of mass forward into a state of instability. We're essentially falling. And we rely on the split-second, perfectly timed symphony of neurological, musculoskeletal, and cardiorespiratory systems just to catch us. It's an absolute masterpiece of engineering.
Okay, so here's our roadmap for today. We'll start with the anatomy of a step, break down the stance phase into shock absorption and forward propulsion, then look at the swing phase pendulum, and finally wrap up with pathologies. Basically, what happens when muscles fail.
All right, jumping into Section 1, Anatomy of a Step, the macro view.
Before we zoom way into the weeds with specific degrees of joint kinematics and individual muscles, we got to set up the fundamental, macro-level parameters. A single gait cycle, or a stride, starts the exact moment one heel strikes the ground, and it ends the millisecond that exact same heel touches down again. Now, this whole cycle is broken down into an 8-phase model. 5 of those subphases are dedicated to the foot actually being on the ground, and 3 subphases happen when the foot is completely airborne.
Now, here is the absolute most crucial takeaway, the 60-40 ratio. I really want you to imprint this into your minds as a high-yield clinical anchor. At a normal walking pace, exactly 60% of the gait cycle is spent in the stance phase. That's where you're absorbing weight and stabilizing the body. The remaining 40% is spent in the swing phase. Oh, and here's a fun fact. For about 20% of the total cycle, both of your feet are on the ground at the exact same time, which is an event we call double support.
Moving on to Section 2, Stance Phase, Shock Absorption.
For this first half of the stance phase, I want you to picture the lower limb not just as a leg, but as this heavy-duty, highly tuned shock absorber. Chronologically, this shock absorption happens right across the first 3 subphases. We start at 0% with initial contact, roll right into the loading response where the foot goes flat, and then transition into mid-stance, which takes us right up to the 30% mark of the total gait cycle. This is the exact window where your body accepts your full weight and officially transitions to single leg support.
What's truly wild here is the precise muscle activation keeping us upright. At initial contact, your hip is in 30 degrees of flexion, while the knee flexes just 5 degrees. Why? Because the quads are firing eccentrically to keep that knee from buckling under you. The tibialis anterior is also firing eccentrically to gently lower the foot flat. Then, moving into the loading response, the knee flexes a bit more, down to 15 or 20 degrees to absorb that initial shock. Meanwhile, the gluteus maximus and adductor magnus contract to start expanding the hip. Finally, at mid-stance, the gluteus medius completely steals the show. It contracts heavily to stabilize your pelvis while you balance on just that one leg.
Okay, Section 3, Stance Phase, Forward Propulsion.
So we've absorbed the impact, right? Now, we've got to shift the physiological narrative from force absorption to force propulsion. We're looking at the final 2 subphases of that 60% stance phase, terminal stance, which is commonly called heel off, and pre-swing, known as toe off. In these critical split seconds, your limb stops being a shock absorber and acts like a tightly coiled spring, releasing energy to launch your center of mass forward.
Let's break down the mechanics of that push-off. During terminal stance, your body weight shifts right over the metatarsal heads. Your hip actually hits its maximum extension here, about 10 to 13 degrees of hyperextension. But the heavy lifter here? That's the triceps surae, your calf muscles, contracting to lift the heel up. Then, as we hit pre-swing, the knee rapidly flexes to 35 or 40 degrees, and ankle plantar flexion cranks up to 20 degrees. That right there provides the final explosive burst of propulsion as your toes literally leave the ground.
Next up is Section 4, Swing Phase, the Pendulum.
All right, the foot is airborne. We are officially in that dynamic, non-weight-bearing 40% of the cycle where the leg is just swinging freely. Think of it like a pendulum. Now, this swing phase is also broken down sequentially: early, mid, and late swing. The main goals across these 3 steps sound simple, but they're mechanically super demanding. You have to advance the limb forward, physically shorten the limb so your toes clear the ground without tripping, and then rapidly decelerate the legs so you're prepped for the next massive impact of heel strike.
So how exactly do the muscles achieve that clearance? Well, in early swing, the iliopsoas heavily flexes the hip to 20 degrees, and the knee rapidly bends up to 60 degrees. By mid-swing, your hip hits its maximum flexion of 30 degrees. This is huge. Your tibialis anterior is firing constantly in dorsiflexion here to keep your toes pointing up. If that fails, you drag your foot. Period. Finally, in late swing, your hamstrings act literally like brakes. They decelerate the forward swing, and your knee locks into full extension right before you strike the heel again.
Okay, so now we know exactly what normal looks like. But let's be real, as future clinicians, your whole job is identifying the abnormal. So ask yourself, what happens to that perfect 60-40 ratio, or those precise joint angles we just went over, when a specific muscle or nerve completely fails? Which brings us to our final section, pathologies, when muscles fail. Let's see how all this translates to patient pathology on the wards.
The absolute most common deviation you're going to see is an antalgic gait. Antalgic literally just means against pain. When a patient has an issue in their hip, knee, or ankle, their body instinctively refuses to tolerate that normal 60% stance duration. It hurts, so they adopt a limp, desperately trying to unload that painful limb. What you get is a severely shortened stance phase on the affected side. Asymmetry is your big hallmark here.
Now, for a classic example of specific muscle failure, look at the Trendelenburg gait. Remember earlier when we said the gluteus medius is the absolute star of midstance, holding the pelvis level? Well, if that muscle is weak or paralyzed, maybe from chronic hip dysfunction or a neurological lesion, it simply cannot support the body during a single-leg stance. As a result, the hip on the opposite, swinging side will drastically drop. You'll often see the patient physically lurching their trunk over the weak hip just to compensate.
But what if the weakness is in the gluteus maximus? Then you get what's called a posterior lurch gait. If you recall, the gluteus maximus has to contract during that initial loading response to absorb shock and keep your trunk from collapsing forward. If it's weak, the patient compensates by intentionally throwing their whole trunk backwards. They lean posteriorly, hyperextending the hip, basically to physically bypass the need for that muscle entirely. It's a fascinating compensation.
And of course, neurological deficits will just completely rewrite the entire kinetic chain. A classic one is the steppage gait. This happens when weak ankle dorsiflexors fail during the swing phase, which forces the patient to artificially lift their leg way up high just to clear the ground. As you move through your rotations, you'll see this play out in upper motor neuron lesions too. You'll see the distinct scissoring of a spastic diplogic gait, or that classic shuffling acceleration you see in Parkinsonism. So as you take all this into the clinic, I want to leave you with the provocative thought. We've seen just how incredibly interlocked this whole 8-phase cycle really is. If normal walking requires this incredibly precise split-second symphony of muscle activation, how might a single, isolated joint contracture, or even just a minor nerve impingement, silently ripple out and completely rewrite a patient's entire kinetic chain over time? Definitely keep that in mind the next time you watch a patient simply walk across the room. Thanks for joining me for this explainer, and keep exploring the amazing mechanics of the human body.